Hi, everyone, and welcome back to the Social Work Bubble podcast. I'm your host, Laura, and I am joined today by some wonderful social workers, Kristin and Tiffany of the Beats by Social Work podcast. Welcome, you guys.
Hey, Hello. Thank you so much for having us here. This is exciting.
Yes. Now, I'm really excited because today we're going to be diving into your jobs in transplant and left ventricle social work. Is that right?
Mm-hmm.
Okay.
Just now, about ventricular.
Ventricular. Okay. Now, this is a role I think is going to be really important to talk about because it's pretty under the radar, but it's one of those things I feel so essential to social work and to supporting people. So I'm really excited about today. As we get started, do you want to introduce yourselves and kind of each of your journeys in social work?
Yeah, that'd be great. I'll go ahead and get started. Hi, everyone. My name is Kristin Malaer, pronounced like Bel Air, but with the letter M. Right. And I am a social worker in heart transplant and left ventricular assist device, also known as LVAD. And I have been doing that for the last 8 to 9 years. So I've been a social worker for 15 years. And I discovered heart transplant and LVAD when a mentor of mine, Beth, saw me working in case management and recruited me and felt like I might be a good fit. And I have never looked back. It has been a wonderful, wonderful career for me.
Amazing. Great. And you, Tiffany?
I'm Tiffany. I'm also a social worker, and I've been in the field for about 18 years. In transplant for the last 10-ish. I think that's what we're going with. It's hard to keep track after a while. I started my transplant journey as a living donor social worker and lung transplant social worker, and then eventually moved over to heart and LVAD as well as VCA. So the organs you don't typically think of. So your uterus, your larynx, your face, things like that. And actually, my current role now is a social work education specialist.
Exciting.
So, yeah, I've had a little bit of a diverse journey, and I kind of ended up in transplant. It was always something that was interesting to me. I've actually been on the other side of it. I'm a donor family, and so the opportunity to be part of the recipient's journey has just been something that's been amazing, and I've loved it ever since.
That's incredible. I feel like I hear a lot about like hospital social work and medical social work, but not this specific kind of social work. And now that like it seems so essential and obvious now that I'm thinking about it. Now, what brought you, like, were you aware of this specific work initially, or it was something that you kind of found?
So I would say for me, at the very least, it was something that I kind of fell into, for lack of a better way of putting it. I've always done hospital social work. That's always been my career path, even just immediately out of grad school. And I worked in the cardiac unit as a discharge planner, which is more commonly what people think of when they think of hospital social workers and case management, that sort of thing. And the unit I was on also cared for transplant patients and LVAD patients. And that's when I transitioned into that role.
Amazing. Okay. Now, what exactly is this work? Like, what does a typical day look like for you? What does it mean to be a social worker in this role?
Well, I'm going to let Tiffany start with that one because she is very thorough in her answer, which I know that we can all appreciate.
Amazing.
Yes, I can't help it. I'm a social worker. What can I say?
Yeah.
No, and you're exactly right. Most people, they hear medical social work and they go straight to discharge planning, which even that I'd say is changing. I know at my institution, we are even individuals that are working as floor social workers are doing more of the psychosocial. The social determinants of health is a big thing that's come out. I mean, it's always been there, right? But in 2024, that it's actually going to be reviewed as a CMS surveyor. And so, we really try to go more towards the psychosocial aspect. But getting back on track, we like to go off on different highway exits sometimes.
Of course.
This is essential work. I mean, when people think transplant, they often don't think about what this means for their life. And preparing for the transplant, the waiting period. So to even be considered a transplant candidate, what they don't show you on the TV shows, which I want to write strongly worded letters to, is the social work component, because this is life. This is real life for people. And so do you have a support plan to get you through the initial recovery process? And for each organ group, it's going to be a different amount of time, and each center, a different amount of time that you need to have a caregiver. Do you have the ability to travel to that transplant center if it's not in your backyard? Some of the recovery, you have to be within an hour of that institution. So maybe you're relocating. And that adds another layer of this: where's my grocery stores? Where do I go to pick up my medications? Thinking about medications, the cost. And now this is where everybody gets a big, oh, you have to be a millionaire, or I'm going to buy my way to the top. It is very federally regulated. You cannot buy your way to the top, at least in the United States of America and most of the countries we work with. You cannot buy your way to the top. And you don't have to be a millionaire, but you have to have a plan. And it's the opportunity for the social workers to actually help you in that regard, kind of doing a evaluation of where are you currently and what do we need to do, thinking about fundraising. There's some wonderful non-for-profit fundraising organizations out there specifically for transplant and medical catastrophes. There is, do we need to displace some funds? Do we need to ask our insurance? Sometimes insurance, when you're thinking about transplant, it unlocks special benefits for transplant. So we're putting a plan together so that we're not setting them up for failure. We're also looking at, do they have the ability to cope, the adjustment? Because a lot of medical things are getting talked at them, and it can be overwhelming, as well as usually when you have an end-stage organ failure, you're not able to do as much as you once were. And so there's that loss of identity, and there's that, who am I? Or individuals that have been sick for so long, who am I when it comes to being well? Now, we don't say cured, because transplant is not a cure. We're trading one diagnosis for another. That's something that we very much always say out there. But it's helping them have a plan. And then if they are deemed a candidate, then the wait becomes. So they're on the wait list, and we don't know when a donor is going to become available unless they're fortunate enough to be a kidney recipient that has a living kidney donor. In some areas, a liver recipient that has a living liver. But for the most part, unfortunately, there's that wait. And we don't know. It could come at 2 a.m. when you least expect it, when you've given up hope. And so our role is to continue to help remind them of their motivation for doing this, to keep them as emotionally and mentally strong as possible while waiting. And then during. So when they're in the hospital, when they get that transplant, and really helping them process that trauma of it. Because even though it's good, it's still a trauma of being in the hospital and doing that recovery. And then really life begins after they've received the transplant. So what does this mean now to be a transplant recipient, to be immunosuppressed, to go back to work, do I explain this? If I'm a young individual that's not married and in the dating pool, when do I bring that up in dating, right? When do and thinking about the extra precautions that go into it. So it's helping people through all phases and helping them live and or develop resilience or coping and for a lifetime.
And then I'll also add, if I may, Laura, also we do a lot of work with end of life. And so Tiffany gave a wonderful description of all the things that we do throughout the lifespan of our patients. And that's one of the things that's really unique about this role is, I've been in it 8-9 years. I have patients I've followed 8-9 years. I've seen them get married, get divorced, have kids, struggle with life transitions in general. But one of those major things is we also have patients who may not survive while they wait for a transplant, and they end up transitioning to the end of life while they're waiting for a transplant, and helping the family do legacy work, do grief, bereavement, and also with the patient. What does it look like coming to acceptance, for lack of a better way of putting it, that you are at a terminal place in your illness journey? And so our entire role here is the stretch of the lifespan with this illness, but also the transition to death.
Just incredible moments to be with someone and to be and to be a support to them. I imagine like in this situation, I'm thinking you have a particular person that's your client, but like family and their support is also pretty integral in that. That's a lot. Like to me, like I mean, it's very emotional. It's very mentally draining. How do you kind of navigate all of those relationships while also supporting the person?
So if I can jump in, but I also see that Tiffany has her hand up, which I suspect you have a very, very good insight into that, also being a donor family. But one of the things that is huge in that is transparency. There's no secrets in transplant. And what I'll also add is, you cannot live successfully with a transplant in a vacuum. It is not a singular treatment option. It requires there's one of the ways I put it that was taught to me. You're basically like an Olympic athlete. You don't show up to the Olympics just by yourself, hoping for the best, right? You have your coach, your trainer, your cheerleader, your pep squad. You have everybody that's getting you there. And that's very much the way that it's successful. But it also means recognizing that your colleagues are in the trenches with you. This is challenging work. And this is not us working against one another, but working towards the same goal. And that goal being, how do we help the patient get to their goals?
Mm-hmm. Wonderful.
And one of the other things I'll add there, it's also the staff, as Kristin said, our colleagues, but even our physicians and our nurse coordinators and our pharmacists and all the people. I mean, there's so many people that go into a transplant, but we're also kind of their social worker as well. So when things don't go the way we anticipated, either by not being able to list a patient because of too many contraindications, or the transplant was not as successful, or it's just life transition. We've been following them for years and they're at the end of their life. And so being able to be a resource for the staff. And it is, when we're dealing with these families, they have a sense of loss from the transplant team as well. So we've had patients that have passed on and the family's like, well, what do we do now? You guys have become part of our family. So it is the dynamics. I mean, it's every piece of social work. When you look at social work and you look at, if you're studying for the LC, it says, what are the components of social work, right? Mm-hmm. Advocacy. And there is the case management component. There is the clinical skills. There is the crisis management, and sometimes all on the same day. Mm-hmm. But it's knowing the family dynamics, because that's going to impact the caregiver abilities. It's knowing the patient's behaviors and their patterns. It's what makes them them. Mm-hmm. And we do psychosocial evaluation. So every patient that goes through a transplant evaluation has a psychosocial, and it's long. And we go through, when you look at biopsychosocial, we go through all of it. And that information then gets brought back to the team and is considered just as much as their lab work, just as much as their scans when making a decision. So it's definitely that Olympic sport, as Kristin was saying, but it's also, you're right there in it. And that's something I don't think a lot of people realize, that this is even an aspect of social work that can exist. Mm-hmm. And then it's kind of like, oh, duh. But then it's also like, whoa, someone's life is potentially in your hands.
Yeah, absolutely. I'm also thinking, like, with what you're saying of like the biopsychosocial being taken seriously is so cool to me, because to me it like speaks to just how social work is becoming more legitimate and like taken seriously as such an important role in these moments. Because I was talking to someone about like nursing, like they had a family member in the hospital or something, and they didn't know who to go to for a question. They were like, is this like a question for a nurse or something? And I'm like, it's like a question for a social worker. But like, and I just feel like people forget what an asset social workers are in those situations.
Well, and I'll jump in on that too, Laura. I totally agree with you. And that's one of the reasons why our presence in the medical review board or selection committee conference is so important, So Tiffany mentioned our biopsychosocial assessment, and those can take several hours to several days because you're rallying the family. It depends on where the patient's at. Are they in the ICU or a general hospital floor or in the clinic, right?
Mm-hmm.
How sick are they? How little or how much time do you have to complete the assessment? But then you present that to what we call the medical review board or the selection committee conference, depending on what your institution calls it. And then the board decides as a whole, is this person a candidate once we put the pieces together? And having a seat at that table is so incredibly important, not only for a patient's outcomes, because there's been data to show that if they have psychosocial barriers, they may have poorer outcomes, but also their quality of life. Would we be offering this patient a service if this is a treatment option that they and their community are not equipped to support? Mm. And so looking at it from that perspective too, because not only, and I'll speak specifically about LVADs, people have no idea in the community what an LVAD is unless two things have happened. One, you work in a cardiac floor, or two, you've watched Grey's Anatomy. And if you're in the second 50% of that, you have an extremely inaccurate depiction of what an LVAD is and what a support looks like with an LVAD. So if you're someone that has this major device implanted into your chest that's keeping you alive and you're going out to a community that has no clue what it is. And so that's also that micro versus macro level of work that social workers can offer. And so, but again, representation in social work is incredibly important, and we do have to fight that we are evidence-based social work scientists. We are scientists in the same right as physicians and as pharmacists. We are scientists from the psychological and mental health perspective.
Absolutely. What does advocacy look like in this space for you, like as a social worker?
Tiffany, can I jump in? I'm so sorry I'm talking so much. I want to make sure that's okay. Okay. So advocacy, that's a little bit of a somewhat of a passion of mine, which is why I got super excited. Again, going back to LVAD, I think that's one of the best examples to use here. So for those in the audience who are not familiar with an LVAD and are probably driving and don't have the ability to Google it real quick, an LVAD is a left ventricular assist device. Very plainly speaking, that is a pump that is implanted into the bottom of the left side of the heart that helps the heart pump the blood to the rest of the body, which is the main part that heart failure impacts, is the heart's ability to pump that blood with oxygen in it to the rest of the body. That includes your other organs and your brain. And so that's one of the big pieces of heart failure that the LVAD treats. Again, like Tiffany said, not cures. But what that means is you have this life-sustaining treatment and machine in your body, but it's not like a ventilator, which is just as life-sustaining, but you're able to be out in the community. You're able to do things, but it also means you're connected to power at all times to keep that pump going 24/7. So what does that mean if you're not able to return to work, or if your general community doesn't even know what an LVAD is? Do you think people reviewing for Social Security disability claims are familiar with an LVAD? And so looking at advocacy can be at the national level. It can be at the local level. Nationally, looking at Social Security Administration with these advanced therapies will be appropriate for resources and utilizing those benefits. Locally is disaster planning. If we have, I'm in Texas, so, you know, Texas is pretty big, but in the part that I'm in, it floods quite often. So we're known for our hurricanes here. And
oh my gosh.
And what does that mean? You can't exactly get your cell phone wet. You certainly can't get an LVAD wet. And having shelters and local community agencies be aware of what it means to have your power connected at all times. I'll just give a brief example of when Texas hit the freeze a couple of years ago. It was this historic freeze, and most of the state was out of power. That meant that our patients could not charge their batteries. And there were some patients who, because they went out to the community seeking help and looking for places to charge, were turned away.
Wow.
And so there's an opportunity for advocacy just right there because,
Mm-hmm.
you know, we hope that there isn't, thank you, Tiffany, for the visual aid. And we hope there's not another historic freeze again, but there's that opportunity to raise awareness and advocate that this is a medically complex patient, just the same as a dialysis patient or a patient on a ventilator.
Yeah, 100%. Wow.
Walking
That's so
life
scary.
support.
Oh, what was that, Tiffany?
What I like to refer to it as is walking life support, you know, except for this is a decision that you're out and about. That's why it's walking versus when you're on the vent, you know, there's not a whole lot that you can do. The goal of an LVAD is to allow you to live life just differently. But that's something to consider when we talk about informed consent. There are risks and benefits to any transplant and any LVAD implant. And so making sure that the patients understand that and are agreeable to some of these lifestyle changes, but really understanding versus agreeable because it's life-saving. So that's my phrase that I like to use is we can save a life, but are we giving life? And so making sure that that's been thought out. And so advocacy looks like that. Advocacy also is huge passion, I think, for all of us in this field too, because it is such underrepresentation. It's also awareness of organ donation. There's still so many myths out there about what organ donation is. And I'm going to be brought to the emergency room and they're just going to try to take my organs. They don't even know if you are a transplant donor until the decision has been made that there is no more quality of life. They don't even know. They're focused. They're not like, wait, everybody stop. Where's the wallet? Check the registry. It's not that. But it's also understanding what living donation. We'd be remiss if we didn't think about our colleagues that are living donor social workers and the fact that our kidneys can be donated. You have one, share your spare. And so kind of raising awareness in regards to that and making sure that you've had those conversations with your family, making sure that just even organizations out there that assist transplant, because it is costly. And so there are groups out there that assist financially, that you're raising awareness and advocating for more resources to go into transplant, for more resources to go into LVAD, because unfortunately LVAD's not as sexy as transplant, which isn't as sexy as some of the other diagnoses. And that's not to say that, you know, one diagnosis is more important than another, but when we think about where people donate, it's often to the bigger named societies out there, we'll say, without naming names.
This sounds like, I mean, just incredibly challenging work, also very rewarding. But I imagine just emotionally on a day-to-day basis, it's a lot. You know, you're kind of leaning on support. What are some of the biggest challenges you face as a professional in that role?
I'll let Tiffany start this one.
I was going to say, Kristin, you look like you have something to say.
When do I not have something to say? Let's be honest.
I think that's one of the most important pieces because this field can eat you alive. And if you don't have someone that you can talk to, but that's the other issue, is you can't talk to people about what happened in selection, right? Because HIPAA. So we're bound by HIPAA just like anyone in private practices as well. But we're carrying that weight. And so you have to learn to compartmentalize like you've never done before and be able to also show up if things didn't go that way or you didn't feel seen or you didn't feel heard in certain conversations. You still got to come back the next day and show up for your patient, show up for your team, show up for the staff, and while dealing with some of these internal struggles. But that is also why you have to be good at what you do. You have to be able to follow the policies. There's regulations out there. There's policies. There's standards for social workers in the transplant field, in the LVAD field, that you need to know those and you need to be your competencies. So one of the CMS guidelines actually requires social workers in this field to have ongoing education. And yes, we all have to get CEUs for our licensure, but specific to the field of transplant so that it shows that you are staying aware, you're staying on top of what's going on out there, which is hard because there's not a lot of places that are just handing out CEUs or handing out education on psychosocial transplant, psychosocial LVAD. Kristin and I are trying to raise heck on that and crusade for that more. But, it's something that takes a lot of effort, and to be reminded of how important this field is, but also for future generations. And that's what things like this podcast is. People that maybe have never thought about social work in the transplant or LVAD, and they're in their master's program. Internships. We do internships. And so check out going into a transplant center. Do they have social work internships? We need more transplant social workers in the world, in general. We need more social workers in general, but specific to this niche, because it's growing. We wish there's a day that we didn't need to have transplants. We would love it if we didn't need transplants, but we're not there yet. And so right now it's raising awareness for organ transplantation. It's raising awareness for the psychosocial support and needs from specifically qualified social workers in the transplant and LVAD field. And it's doing that with grace and integrity as well, and following our institutional guidelines, following our NASW code of ethics, and also continuing the crusade to raise that elevation of the field.
And what I would say for my answer is, I'm trying to think of a kind way to put it that's still very clear and to the point. Ultimately, the hardest part of my job is I don't want anyone to die, but I don't want anyone to suffer either. And so we learn about dialectics in social work, that you can sit with two conflicting emotions at the same time. Yeah. And so sitting with that, I don't want them to die, but I see that they lack the resources to live successfully with this therapy. And how do you cope with that type of a conflicting emotion as a professional? And then going into the compartmentalization piece. So there is many times when we will present to the medical review board, and you will feel as if you're not, or selection committee, and you will feel as if you're not heard, as if the risk factors that you're presenting to the physicians and leadership, that it's falling on deaf ears. And that may not be the case, but it is understandable and easy to see why a clinician, a social work clinician, would feel that way when everything we have been taught shows that this is going to be extremely high risk. And there are risk factors associated with somebody that cannot live successfully with a transplant. That may be for reasons totally outside of their control, but it puts them at risk for rejection, hospitalization, and suffering, ultimately. And so the hardest part, I feel like I have to give this whole backstory to make the whole...
It's important, yeah.
Yeah, the hard part actually means something.
Hashtag social work.
Yeah, so that's the prequel, but the hard part is, fine, you presented, it should not be one person making that decision anyways. It's too big of a decision to have one person. That's why we have a board. But let's say that you have all these risk factors. You present that. It falls on deaf ears, or it doesn't, but they still decide otherwise. You're overruled. You have a patient that goes for a transplant or an LVAD, and every single thing that you saw as a risk factor comes to fruition, and you are the social worker that has to sit next to them while they suffer. And so the hardest part for me to cope with personally is then when your fellow interdisciplinary team members come to you and say, why didn't you see this coming?
I would lose my mind.
And you have to find the grace to turn around and say with kindness, you did see this coming, you presented those risk factors, and the decision was made otherwise. But there is this huge misnomer that social workers may not be thorough, they just pass everybody. And that's not the case either. So how do you sit with, I don't want anyone to die, but I don't want anyone to suffer? How do you cope with when your risk factors are falling on deaf ears while still fighting for a seat at the table? And then how do you sit with a patient suffering knowing you saw the risk for the suffering before it started. So that's what's hard.
Absolutely. Oh my gosh. Within kind of those boundaries of confidentiality, do you find like leaning on colleagues for support is something that's really helpful since it's kind of limited on what you can actually say outside of work?
I would say absolutely. And Tiffany and I both are in leadership roles in professional organizations. And that right there is a huge, huge piece of coping. Get involved with the specific organizations that understand your specific line of work.
Mm, absolutely. It looked like you wanted to say something, Tiffany.
Yeah, I was just going to say that with transplant social work especially can be very isolating because sometimes you may be the only social worker in that organ group. And so that also is tough because you don't necessarily have the team to lean on, the colleagues to lean on. So you end up leaning on, you know, your managerial support, or you lean on your nurse coordinators or other members of your team. Because sometimes even outside of transplant, if your managers, supervisors aren't in transplant, or if they weren't in the room during that discussion, even to try to explain how that discussion was can be tough. So it is, you know, finding someone from that team that you can align with if possible, but also as Kristin said, that was the professional organizations. That has been a game changer for a lot of people, I'd say.
Certainly. I feel like that's also where you can just exercise some control over these situations where you just feel like a little helpless, you know, kind of just going through the process like, okay, told you so. Now here we are.
Exactly.
I do wonder, the people that you're working with, the people that are getting transplants, are these patients typically people that you're with for a few years? Like or not? Does it just depend on the situation?
Depends on how sick they are and depends on what organ group you're working with. So some people have a longer wait time. Some are based on how sick you are. So for instance, we talk about lung and heart. We could be meeting someone that day and be having a selection conference that evening. And so we just met them. They were transferred into our hospital and everybody's working very, very quickly because we have to make a decision. The other part is sometimes it's decisions of what are even the next steps in treating the patient because we don't want to do harm. So we don't want to put them on to some type of a treatment that we're going to then have to take them off if they're not a candidate. Of course, we're going to work diligently no matter the situation, but these are different. I mean, you're thinking 4 or 5 steps ahead at all times in these roles, but there's times where you meet a patient and they're sick enough to need a transplant, but they're holding steady. And so they could be waiting for years. And so you're knowing them during their wait phase. So the leading up time could be anywhere from a couple hours to a couple of years, that you're spending with them before the decision or before the call comes in.
Wow. Now, what's been a particularly rewarding experience? I feel like a lot of this, like, it can feel very challenging. It's very emotionally overwhelming at times. What's been an experience that you really kind of hold dearly to yourself?
It's so funny. I know there's like so much silence with that one. So for me, I would say that it's so interesting because transplant patients, transplant recipients, there is this pressure, and I've had several patients share this with me. Of course, I don't know from personal experience, but that there's this pressure that I've been given this gift of life that because somebody passed away, and there is no correlation. They were going to pass away regardless.
Right.
And they made the choice to donate their organ to a stranger at the time of their passing. But now they've been given this tremendous gift of life. Now they have to go climb Mount Everest. They have to go you have to go figure out a way to win a Nobel Peace Prize. Like, you can't just live an ordinary, normal life. And to me, the biggest wins are the ordinary life things. I've been bedbound for months and now I get to go to my kid's graduation. I got to check the mail today and I want to brag about that to you. Like, nobody needs to climb Mount Everest. I saw a meme the other day that basically said that all the dead bodies around Mount Everest were once people that thought they could climb to the top. So
I've seen that.
yeah. And it's like, no, you don't have to kill yourself to accomplish this grand feat. So let's celebrate the small wins. I have a patient who went to seminary school and they wanted to be a preacher their entire adult life, but all of their time and bandwidth was spent being sick. And now this person has started an organization for spiritual support for transplant patients. Wow. They finished seminary school and now are preaching. That's cool. And that's amazing. So that's the win for me.
That's incredible. Yeah.
I think my win is, honestly, no matter how many transplants happen, it's amazing every time. And I can honestly say that because some people may say, well, it's like, that's your job, right? You've seen how many of them, but patients aren't just a number in the transplant world. And every time that a patient gets that organ they've been waiting for, there's some people that don't want transplant, but they know they have to. Like, there's some resentments against it for sure. But when they see it and it works and they feel like they're getting a form of life back, not their life, because that's the thing. It's a new normal. You're not going to go back to the person that you were. There's no way you can, but it's that new normal. And when they come with that acceptance of this new normal. And so that would be one of my most rewarding, is just seeing it. But then the second one I would say is the patients that you truly see the difference that you make. Whether they say thank you to you or not, they're not going to, but like you can see that transition of how resistant or how non-adherent they might have been because they didn't fully understand, and you get to work with them. So sometimes you're having multiple sessions with them in the pre-phase to try to just get them to a different level of, this is where we are, and you can either continue to resist it or we can go with it. And how do we get there? And so watching that difference, or telling someone they need to get involved in external counseling, because the scope of our practice, we can do brief counseling, but not necessarily for the full on gamut treatment plan. I mean, we write treatment plans and everything, but we can't necessarily see them as frequently as if they were to go to an external. So we have them see someone in the community on top of with us. And watching that difference and them saying, man, I was so mad at you for making me go to counseling, but I have to say thank you for making me go to counseling because it's changed me. And so watching that shift in people's perspective and thoughts, just, I don't know, I still get excited I'm thinking about multiple patients that I've had that happen with, and just like, oh, it's awesome.
That's huge. That's huge. Because it's also, I mean, obviously there's a lot physically going on, but to see someone kind of have that shift mentally and emotionally into acceptance, like that's exactly what will allow them to live a fulfilling life afterwards. How exciting. Wow. Okay. What specific skills, we've touched on advocacy, there's case management, there's a lot of like emotional support and kind of stuff that goes on. Any particular like social work skills you really gravitate towards or use pretty frequently on a day-to-day basis?
All of them.
All of them. Yeah.
It depends on the person, right? Yeah. That's the biggest thing, is that it's not a one size fits all. And so we really are pulling from our bag of tricks. Sometimes it might be doing some CBT with a patient. Sometimes it might be just doing some talk therapy with them. Sometimes it's figuring out what the root is and peeling back the layers. And the critical and clinical skill set is, I'd say those are the two. I love to ask my staff in the role that I'm in now. I ask whenever a staff member comes by my office where I'm around them, I say, what'd you do that was clinical or critical today?
I love that.
And it just makes them think about, what are we doing? What skill set as social workers are we using on a regular basis? And you typically are using something. It's just a matter of reminding yourself. But the number one skill set I'd say is probably rapport building. You have to be able to rapport build quickly because you're asking very intense questions very personal questions very quickly. And so you have to do it in a way that is not so intrusive, even though it's intrusive.
Or abrasive.
And the understanding of why you're asking those questions, but being able to humanize it. I mean, that's the biggest thing, is humanizing this whole process.
Yeah. That's so important. That's so interesting because, like, in my role, like, I'm a therapist, but there's no time limit to when I work with people. And so if there's something where, like, they're just not ready to talk about it, or something, like, I'm just like, oh, we have all the time in the world. Like, it's fine. In this situation, it's like, okay, we have to get information. We have to, like, kind of figure this out. Wow.
Yeah, absolutely. And I love that Tiffany brought up rapport building, because that is, it is very difficult when you're learning that, because it's something that it's also challenging to teach somebody too, because everyone has their own style of how you build rapport. And and that's one of those things, the practice of social work, it is practice throughout the journey. But you also, one way you build rapport with one patient is not going to be the way that's going to work with another patient, right? And so being able to gauge nuances and that sort of thing. And you know, the famous meet the client where they're at, meet the patient where they're at thing. And it's like, okay, well, that's all well and good, but what the heck does that really look like?
Right.
Realistically speaking. And so, like, if I may just give an example, I had a patient that was in a lot of pain, and they were struggling to take medications. The nursing staff was having a hard time because they were saying, why is this patient so non-compliant? And there was a big disconnect there. Everyone was right in their own perspective, but there's this really cool, parenting book, and it basically says when you're working with your kids to lean more into connection over correction.
I love that.
And I think that is really something we just need to take into human relationships in general. And so I went to the patient, and they said, I know you're just going to tell me to be grateful and be positive, and I need to just think positively. I was like, no, you can't positive think yourself out of a crappy situation. And this is a crappy situation. So let's sit with it. And he just immediately started laughing. He's like, don't laugh, that hurts. But then the ice was melted. We were okay. And so I think that, to Tiffany's point, rapport building is such a huge skill to fine tune and put your attention and bandwidth on.
Wow. I mean, it's like the foundation for moving forward after that, from really doing anything. Wow. With that, as we kind of wrap up, what is one piece of advice, which I know is a very hard question, but that you would give to the social workers listening?
I think Tiffany wants to think about her answer. So I'll jump in, and that is, you can have all the right answers in the world, but I still hone in on connection over correction. Because if you have a patient, if you have a client who is doing every single thing that looks like it's not in alignment with their goals, they're not even going to hear you unless you're showing them that you're sitting next to them and not standing over them. So that's my piece of advice, and that's something I feel like can be taken into any field of social work.
Yeah, absolutely. Just that human relationship.
And that goes with something that I recently heard in a training I was doing, and I loved it. Just because somebody gets mad at you does not mean rapport is lost. It's a matter of continuing to show up. And I think a lot of people are uncomfortable in conflict. And, they're mad at me. I can't be their social worker. I can't. But the thing is when you continue to show up for someone, they see that. And so it kind of goes along with Kristin's aspect, but I just want to put that out there of, just because someone's mad, someone gets angry, doesn't mean the rapport is lost. My advice as a whole would just be, look into all aspects of social work. You know, one social work path is not necessarily the only path. And sometimes we think, especially with grad school, that kind of makes us be put into boxes in a sense. What is your emphasis going to be? What is your focus going to be? That there are so many different avenues out there. And so explore it. And if you have any interest in transplant or LVAD social work, you know, hit us up, go to, do some Googling on your own. but just know that you make your own limitations. And that's the thing, is that you can forge your own path.
Wonderful. This has been such a great conversation. I love it. I'm so glad that you guys were on.
I totally agree. It's been great.
Yeah, we appreciate it.
I think you're the first social workers in transplant I've ever even heard of existing. I'm really,
that's
we love talking about it.
Yeah, because we can't stop talking about it, and our peers are like, would you please stop talking? And we're like, no, there's so many people that need to hear about this.
Yeah. Oh my gosh. Now for those listening, where can they keep up with you and kind of follow your guys' journey?
Yeah, so Beats by Social Work is our podcast. We can be found on Instagram. We also have a website, beatsbysocialwork.onpodium. But it's much easier to find us on Instagram and just typical social media as well.
Wonderful. Well, thank you so much, Tiffany and Kristin, for coming on today. For those listening, don't forget to like, share, follow the podcast, and we will see you next time. Thank you.
Thanks, Laura.